third star of the day. He's it will be the desert for this our heavy male. And it is one, for me, it is one of the best speaker. I like to listen to him. And he is Dr. Sohel Ahmed, consultant of anesthesia and ICU in in Hamad Medical Corporation. He's my colleague in the same workplace, but with different interests. Dr. Sohel, he received higher training in anesthesia and ICU from Ireland with Dr. Saad. He's a fellow and examiner with many academic institutions like colleague of anesthesia of Ireland, UK, and European Society of Anesthesia. And also in Hamad, he's responsible for about education and examination and evaluation for the people. And also he's very interested and doing a great job in our institute about risk management in our medical service, really, every day. And he is also, as I get the line from Dr. Fawzia, responsible about mortality and morbidity in our place. The other day I spoke with Dr. Sohel about the era of COVID and the other coming, we don't know what's coming in the future from pandemic, and with a real extensive use of oxygen therapy. And I was thinking in what's called a commercial way to asking his opinion about to make like industry for oxygen, because this humanity will need an oxygen. As I was thinking, believe this is a best gas and unique gas, and this gas will not survive at all. But I was surprised when Dr. Sohel told me most of the time the oxygen is not a friend. And I get also one comment from Prof. Fawzia about that use of oxygen from the saying was increase the mortality, use of oxygen, like even Brisdex and use of oxygen. So the lecture presentation of today is mixing with each other, really. So so I'm just still listening for the presentation for Dr. Sohel about that oxygen friendly or not to start our industry. And the theater now is for Dr. Sohel to tell us whether the oxygen is friend or an enemy. And thank you, Dr. Sohel, for joining us today.
Thank you, Yasser. And of course, these nice words was after I paid Yasser 50 riyal this morning to say these nice things about me. It's actually also quite intimidating to give a presentation after two eminent presenters like Prof. Fawzia and Dr. Omar. So I would appreciate if you can bear with me. I'll try to be, short and sweet. So today I would like to discuss with you about oxygen and excuse me, why oxygen is not always our friend as a lot of anesthetists believe. No conflict of interest about that, but let me share with you this scenario that I went through a couple of years back, where I had to anesthetize this 51-year-old very pleasant lady, ASA2. She was just, her weight was just a bit on the high side, no other comorbidities. She was coming for a subtotal thyroidectomy under GA. GA went very well, bit of SIVO, air, rocuronium, reversed with Sugamadex. We gave her some morphine, paracetamol, non-steroidals, antiemetics, everything was hunky-dory, okay? I saw her as I usually do. I saw her in the recovery. 20 minutes later, she was pain-free, she was happy, her blood pressure was well controlled, her saturation was 98 in room air, and she was breathing very, very comfortably. Okay, so she ticked all the boxes. We were about to discharge her, all right? When it happened that there was a surgical resident there who advised the nurse to keep her on oxygen for the next few hours. So, I mean, that wouldn't be my usual practice to prescribe supplemental oxygen for the ward, especially if the patient doesn't need it. Okay, so I got into this argument with the surgical resident. Why does this lady need to be on supplemental oxygen in the ward? Now, the happy resident immediately produced for me this guideline from the WHO, okay, which deals with the prevention of surgical site infections. And in this guidelines, in their page 17, they clearly recommended that all adult patients who undergo general anesthesia should receive 80% of FiO2 intra-op and should continue to receive oxygen for up to 6 hours, and that's in an attempt to reduce their surgical site infection. Now, to be honest with you, I was quite taken back by that, especially that they put that as a strong recommendation, though describing that the evidence behind it was moderate. Okay, so I had to do a bit of digging there. And what they wrote was very simple. So they said, if you give a high FiO2, you're increasing the partial pressure of oxygen at the wound site. And by this, you are generating reactive oxygen species, which will promote the killing of the pathogen. Okay, not only that, it will also promote collagen formation and epithelialization, hence healing of the wound. All right, so that was the explanation given, and the happy surgeon thought that he had got me there. So, and he also was very quick to produce this paper by Hopf and others, which talked about hyperoxia and how it is like the silver bullet for treating infection and preventing infection in the first instance. And in that paper, I'm not going to bore you with all this biochemical stuff. What it says in a nutshell is that they noticed that if you have a healing tissue, the closer it is to an oxygen supply, i.e. a capillary, the quicker it heals, while the cells which were further away from the capillaries had a higher concentration of lactate and were poor to heal. Okay, now this was done on a rabbit ear chamber. Quite a few poor rabbits had to go through this. But digging further, I found that also in the quite a high published, high impact journal like the New England Journal of Medicine had the same belief that oxygen-dependent microbial killing by phagocytes, that the phagocytes depended on the oxygen concentration to carry out its deal. And they explained that by saying that the killing mechanism of phagocytes, actually, there were two arms to it. So oxygen dependent and oxygen independent, but the oxygen dependent was far much efficient compared to the oxygen independent areas in promoting like nitric oxide synthase, which is a very good promoter for pathogen killing. So there is a bit of a literature behind it, to be honest. And I mean, if you think about it, hyperbaric oxygen therapy also is used to treat infections. Now, we have a big department or big section in our department dealing with hyperbaric oxygen therapy. As you know, it is mainly used for divers and for those who get the blends, decompression sickness. But most of our hyperbaric oxygen therapy used here in Doha, the last statistics they talk about that about 92% are patients who have infections, mainly due to peripheral vascular disease and diabetic ulcers and stuff like that. So they use this high concentration, high pressure of oxygen as an antimicrobial. Okay, so let's talk a little bit about oxygen because it is becoming an element of interest. So this paper published in Nature by Stolper and his colleagues, these are scientists who spent most of their lives in the North Pole, looking for origins of life and stuff like that. So one of the things they did, they pulled these old ice cubes, okay, that were deeply buried in the North Pole in four different locations, and they analyzed the gas inside these ice cubes. And you can see there in the graph to your right, you find that actually the concentration or the percentage of oxygen in the atmosphere has not changed that dramatically at all. So they look like back 800 years, and the oxygen concentration in the atmosphere has hardly changed by 1%. Okay, this is unlike the CO2, for example, which for a long time was steady, but after the Industrial Revolution, you can see that it is skyrocketing and causing all these problems with the climate change and so, despite what some leaders thought at that time. So, can oxygen really be an enemy then? I mean, it has been there for decades, it hasn't changed. Can it be an enemy? Well, Paul Bert, who's a known physiologist, a French physiologist, and also a politician, okay, was the first to describe the unwanted events of oxygen, and he named it after himself. It was Paul Bert effect. Okay, and in his description, he said that being exposed to oxygen for a long time causes things like visual field contractions, dizziness, headache, tinnitus, nausea, and vomiting, and even convulsions. Okay, this was seconded by J.L. Smith of Belfast, in which he carried a number of experiments of oxygen in animals and found that if you give an animal 100% oxygen long enough, they will eventually develop pneumonia. So giving a lot of oxygen doesn't seem to be a good thing. Now, Griffith, and that was only in 1992 in chest, he had these volunteers in which made them to breathe or inhale 50% oxygen for around 44 hours as a mean exposure. And even at this low, relatively low concentration, he found that there was clear evidence of of lung trauma, okay, which was produced by, which was picked up on the bronchoalveolar lavage that he carried on them. So too much oxygen does come with a cost. It's not all hunky-dory. We know in our medical practice that retinopathy of prematurity is linked to the amount of fractional inspired oxygen. That's why hardly in our neonatal ICUs we would be very reluctant to increase our oxygen from 25, let's say, to 30%, because we're aware of the retinopathy that can happen. We know that it causes bronchopulmonary dysplasia. Okay, and not only this, it also can arrest the septation, which is happening at the sacral stage of development in the lung. So there is a lot to be said about giving too much oxygen. In this paper by Tokoyoni and others, he related the production of reactive oxygen species to a lot of pathologies. So he said that if you give too much oxygen, if you give oxygen, you at a cellular level, at the early stages, will promote that cell to proliferate and regenerate, which is good. However, if you increase their FiO2, you will run in all types of troubles, including cellular program deaths like apoptosis and necrosis. And this is related to mutations, carcinogenesis, atherosclerosis, and really, you name it. All the problems can happen from this ROS. Even the kidneys, in the same article, he showed a specimen of rat kidneys, one on the left, which is a normal specimen, and you can even identify the glomeruli very easily, and one on the right, which was the same specimen after being exposed to oxygen, 100% oxygen for a few hours, and you can see that it is poorly differentiated now. So in shock, also, this is the last one I would like to in terms of histopathology. So if you can look at this mosaic, it's not very easy to interpret, but if you can look at the top left corner, this is how your cardiac myocyte looks like. Now, if it is exposed to hypoxia, which is 5%, that's quite severe hypoxia, you can see that some of the cells take a spindle shape, and you lose this conformity of the picture. The same happens when it is hyperoxia, if you can compare them. And actually, if this hyperoxia is intermittent, meaning that you give high FiO2 followed by a normal FiO2 followed by high FiO2 again, the effect seems to be enhanced. Okay, so not only hypoxia is detrimental, it appears that hyperoxia is as evil as well. But I mean, most of us are clinicians. Let's be practical. I mean, how many of us look after an ear, a rabbit earlobe, which has been chopped, or been looking at some histological slides? We rarely do this, to be honest, in our practice. So what kind of clinical evidence do we have for or against oxygen? So one of the landmark studies, in my opinion, was the AVOID study, which was published in Circulation in 2015. And in this study, they looked at those who had the STEMI, ST elevation MI, between those who received oxygen and those who did not receive oxygen. Okay, and what they found was quite astonishing. So those who received oxygen actually were at a 6-fold chances of having a repeat MI within their hospital stay. Okay, and what I found especially interesting, because I'm involved in a lot of resuscitation happening in the hospital, and what I find very true is that the arrhythmia. So the more we give the oxygen, the higher is the chance that they will go into an arrhythmia, even if it's not an arrest arrhythmia, it is one of the SVTs or the AFibs or stuff like that. And in this study, they found that both of these outcomes were quite statistically and of course clinically relevant. So their conclusion was that in supplemental oxygen in STEMI, in patients who did not have hypoxia, okay, increased their myocardial injury and was also associated with a larger myocardial infarct, because in this study, they had all their patients having a cardiac MRI at the time they had the infarction and 6 months later. And they noticed that the size of the infarct increased quite dramatically in those who were receiving oxygen despite not being hypoxic. All right. The same here, or another study, sorry, which was published in Stroke, all right, which looked at the stroke victims who had received also supplemental oxygen without being hypoxic. And this is quite important to stress that they were not hypoxic, because the treatment for hypoxia is to give oxygen. But what we're trying to say is that you don't need to give oxygen if the patient is not hypoxic. And you can see, just to save some time, I just put the Kaplan-Meier graph there, and you can see that the separation of the graph happens quite early. So the probability of survival improved if these patients did not receive oxygen, okay, as compared to those who routinely received oxygen. The same can be said about in traumatic brain injury, and in my ICU, we get a lot of those. And you can see the Kaplan-Meier here also, which shows to survival, it separates at a very early stage. Even in day 1 and day 2, you can see there is a separation in the Kaplan-Meier, quite a significant separation, very early at the time, and in favor of those who did not receive oxygen if they were not hypoxic. In resuscitation, they published those who were in hospital cardiac arrest, and they compared between those who had hyperoxia, okay, so their PO2 was quite high, versus those who were normoxia or non-hyperoxia, as they put it. I think the cutoff they used was around 150 millimeter of mercury, and it was very clear, shown here by the forest plot, that those who were hyperoxic tend to die more frequently than those who were normoxic or did not have at least hyperoxia. Okay, in ICU, this has been quite an established fact. It's really now we're trying to say how low can we go. All right. So there was a number of trials. One was by our colleagues in New Zealand, Australia, and New Zealand. Okay, which was the CLOSE study. They compared two groups, conservative versus liberal. You can see that the conservatives, they got their saturation here was sitting between 92 and 93. They had low PO2s, low FiO2s, and despite that, they had low time on mechanical ventilation. That means they were liberated from the ventilator quite quickly compared to those who were on high FiO2s. Okay, I'm sorry for this crowded slide, but what, in a sense, what they're trying to show here was that, sorry. Okay, what they were trying to show here was that there was a difference in as you can see, there was a difference in all the characteristics related to the oxygenations of the two groups. However, the outcome was not statistically different, which means that hyperoxia did not provide any advantage over normoxia in the ICU patients. Another study, which was in JAMA, was also by Massimo and colleagues, and they also did quite a similar thing, conservative versus conventional. And in their study, which included more than 400 patients, they saw that the primary outcome, which was ICU mortality, was quite a hard outcome, okay? Plus their secondary outcomes were far much in favor of having patients receiving conservative oxygen therapy rather than the conventional oxygen therapy. So, hyperoxia. It causes absorption atelectasis. We know that. It decreases our functional residual capacity, okay? It obliterates our hypoxic pulmonary vasoconstriction, hence increasing the shunt. It might cause CNS toxicity, as Paul Bert described, causes pulmonary fibrosis and dysplasia, as we know, acute hyperoxic acute lung injury, okay, which I think I saw a few cases of that during the COVID pandemic. There's a question whether it increases mortality after resuscitation or not. we know for sure that it does increase the arrhythmia rate, okay? And it might cause an increase in the reinfarction after STEMI. It might increase the mortality in ICU because of fire. And also there is an interest now showing up in the chances that anesthetic in general and oxygen specifically, if it causes recurrence of cancer. And this is quite interesting because this study, the Proxy study, was one of the biggest studies in which the WHO based its recommendation to give high FiO2. Okay, so this was a study designed to see the long-term mortality associated with inspired oxygen after abdominal surgery. They looked at surgical site infection was their primary goal, and you can see that it did not even achieve statistical significance. So the p-value was 0.5. Okay, but despite that, it's one of the studies that they did use for their recommendation. However, if you do an ad hoc analysis to this study, it's quite interesting because if you see the Kaplan-Meier here on your left, the ones in blue are the 30% oxygen, those who received 30% oxygen. The ones in orange or brown are those who received 80%. And you can see easily, okay, that the line starts to divide almost 200 days after the surgery, okay? And in this, it favors the 30% oxygen, okay, the mortality. And if you divide this group into the groups who had cancer and those who didn't have cancer, you find that in the group who had abdominal cancer, it still favors those who received 30%. Those who received 80% actually did worse and died much earlier. This does not apply to those who were non-cancer patients. The line almost does not separate, which raises the question is that why those who received high oxygen died earlier, okay? Was it a recurrence of the surgery? Did it metastasize, okay, after receiving high oxygen? I mean, this is things that you should consider. So even though they claim that the surgical site infection was less with the high FiO2, in general, the patient seems to die much quicker, if I say, compared to those who had low FiO2s. So this is the studies which all looked into surgical site infection, and you can see that the last 5 are those which the WHO based its recommendation on, and forgetting or completely turning a blind eye to another 11 studies which showed that there was no correlation between the FiO2 and surgical site infection, or it was a negative study. Okay, now this didn't go without notice. The WFSA was very quick to respond. They urged the WHO to reconsider their wording and the recommendation, okay, because there is no evidence to support this high FiO2, okay. Manuel Wenck and his colleagues also wrote a very nice article in Anesthesia Analgesia against this, what they call a dangerous reductionist approach. So I'll try to conclude here. My take-home message really is the more is not always the merrier. More does not mean better, okay? More only needs better if needed. Number 2, the second thing, I think once we go back to our anesthesia and our theaters, before we dial up that oxygen knob up or down, we should always think, because oxygen is a drug, you don't give a drug without an indication, and definitely you don't give it in doses which are unneeded. So if you want to put the patient on 50% oxygen, you should ask yourself, why 50? Why not 40? Why not 60? You have to have a solid argument with yourself on how you are going to titrate your oxygen therapy. Okay, we definitely need more studies to be done and have our say on the topic. I thought it was a bit ridiculous from the WHO to issue that kind of guidance without properly studying the evidence. And I think one of my messages is also, I think the WHO needs more anesthetists on its board. It needs more perioperative physicians. WHO, I do respect the agency a lot. I think it has done a lot to mankind, but it is dominated by our colleagues on public health. And I don't think they have enough clinicians who study the evidence quite well, and definitely they don't have enough anesthetists or perioperative physicians to guide it. I'll leave it there. The last thing I'd like to quote was from Paracelsus, who says that poison is in everything. No, there is no thing without a poison. The dosage makes it either a poison or a remedy. And if this is true, this is very true to oxygen and oxygen therapy. Thank you very much.
Thank you, Dr. Sohel, for this really fantastic and guide to me, because you're disrupting now my business. And second thing about my beliefs, because what I know now is a new thing and new update. And I remember I read an topics a few days ago or 1 year ago about the ayah of verse of Quran, إن كل شيء خلقناه بقدر. Everything we created in meticulous way, because I read about Rio de Janeiro, when the oxygen for pollution coming down a little, about 19% or 80%, the people can't breathe and get many problems. And also the same, if you give 25 for a patient for a long time, it can make the same effect. So the complication, as you said, oxygen is a drug, it must be titrated in a special way. And if you need 30, you don't need to get 50, because even we know all this fact, all the problem of oxygen, we're still looking for the oxygen saturation. For example, we give 50% and oxygen saturation 99. I don't know why we don't go for 30% and the oxygen saturation is not 99. And you revise all the data and update about the oxygen. And really, I have one question here about, I think ozone is some form of oxygen, O3. What about ozone? You know any data about ozone as an anti-aging drugs, and most of the people taking this ozone for treatment of many things?
Yeah, I've heard about that as well. Yeah, ozone, as you know, it's O3 versus O2. However, this extra atom of oxygen changes a lot of the characteristics of oxygen per se. I'm not very familiar with studies that looked at it, to be frank, and how effective or how damaging is it. So not really. It's not something that I have experienced.
So can it change, if there is a data supporting, can it change our business from oxygen to ozone? What do another question?
A very good business mind, though.
Yeah. Another question from our colleague Mustafa. He said, Hyperoxia, what is the cutoff? For example, BO2, 150 millimeter mercury, and for how long then it will be hard? So
Yeah. That's a very good question. Yeah. That's a very good question, Mustafa. Actually, different studies had different cutoffs for the hyperoxia. Some studies had a cutoff of whatever exceeds the normal PO2, everything more than 110 millimeters of mercury, whatever they consider as hyperoxia, while in other studies they only consider it if it exceeded 150 millimeter of mercury. Well, what we know for certain is that if you get oxygen that you don't need, you are causing harm. So my cutoff will be that any amount of oxygen that you need that you're taking without need. That's my definition. And as Dr. Yasser, you just said, amended that if somebody is saturating 99 on 30% oxygen, you don't need to put him on 50% oxygen. This is just 50%. This 20% extra is not just going away, it is causing some harm in your body.
Just I don't have any more question for anyone. Just have a question, because really the presenter today was very good in time and was going deeper, more than wider, concentrated. So I think I have another question here in question book. What cut-off value of premature baby? Speak about, because the oxygen is very hazardous for premature baby. What is the cutoff for these people, and the cutoff saturation and oxygen content of the problem?
Yeah, so although this is a little bit outside my expertise, but for neonates, those who are 28 days or less, okay, these are the highest. This is the group with the highest risk of having retinopathy of prematurity. Okay, and definitely if they are born preterm. And these patients in which all these angiogenesis is happening, you really want to keep their oxygen to the minimum. So usually the cutoffs that we used to do in my days in neonatal ICU, we kind of accepted any saturation above 88, and we titrated the oxygen very, very, very carefully. You really had to have an expert to agree to increase the FiO2 from 25% to 28%. That was a dangerous, that's how serious it is. This is a dangerous call to increase the oxygen by 3% in this kind of group of patients.
I have maybe a last question, and maybe this is a comment more than question, but you can just give your comment. And this is our colleague Mohammed Sulaiman, and he's very interested and excited all the time. One of the supporters for MEGA Learning, and he's very good. He said, "Thank you very much, Dr. Sohel, to see you in MEGA Online as a member, and thank you also for sharing us, Dr. Sohel. You add value and information for us. We need to see you again." And he said your presentation could make use oxygen more economics as an economy to be used for those who really need, especially during COVID time, because you know that most of the country have a shortage of oxygen, because abusing this oxygen. What's your comment?
That's very good. Thank you, Mohammed. He's a very dear colleague. You're absolutely right. Absolutely right. I mean, the demand on oxygen has been incredible during the COVID era, and we all watched in horror big countries like India running out of oxygen supply. Which is quite horrifying to be honest. Rational use of oxygen definitely helps. But however, I do not want to steer my colleagues away from not giving oxygen at the same time. Hypoxia also, of course, kills. We just have to titrate it. It's the message I really want to get across is that it's a drug. It's like giving beta blockers, giving steroids, giving anesthetics, anything. There is a dosage with an intention to treat a specific reason. Even I made this in theater over and over again. If a patient is dropping their saturation, okay, and I find some of my colleagues just go up on the oxygen, yes, as a rescue measure, I have no problem with that. But then you have to figure out, why did he drop the saturation? And if we don't deal with that, and we just tend to accept that, okay, we'll just run the rest of the case on 100% oxygen or 90% oxygen, I think this is not the right thing to do.
Thank you, Dr. Sohel. I don't have anything more. And thank you for everyone.